Hello dear viewers, in this video I am going to discuss pharmacological therapy for the management of distress and agitation in ICU. This is part 2 where I will discuss pharmacological management, mainly drug selection. I am Dr. Sunil Garg from Essentials of Acute Care. For patients in whom treatment of underlying critical illness and non-pharmacological strategies which we discussed in my earlier video have failed to achieve an appropriate level of sedation means calm and cooperative patient, pharmacological agents should be administered in such condition. This approach reduces the risk of acute and chronic physical and emotional harm if distress is treated adequately. Once sedative agents are selected and initiated, the dose and/or frequency are titrated to a set target. For the most part, the administration of sedative analgesic medication should be based on observed agitation and not on assumed distress unless the patient is on neuromuscular blocking agents. This strategy reduces the risk of oversedation. Preemptive pain strategies are reasonable, like giving pain medication prior to turning, suctioning, or dressing change. Patient undergoing neuromuscular blockade should empirically receive pharmacological sedation and analgesia since neuromuscular paralysis without sedation or adequate pain control is an extremely frightening and an unpleasant sensation. Additionally, assessing and treating underlying delirium, pain or anxiety is impossible in paralyzed patients. Sedative analgesic medications that are commonly used in the intensive care unit include opioid analgesics like fentanyl, remifentanil, non-opioid analgesics like acetaminophen, propofol, dexmedetomidine, benzodiazepine groups of drug, antipsychotic medication, sometimes barbiturates and ketamine. All these agents differ in their amount of anxiolysis, analgesia, amnesia, and hypnosis. Regarding selection of agent, it should be or it must be individualized since no sedative analgesic agent is sufficiently superior to other agents to warrant its use in all clinical situations. Select an agent that targets the etiology of the distress, means the cause of distress, whether it is anxiety, pain or delirium or combination of these. Identify any modifying variables that may influence the choice like pharmacological and non-pharmacological factor such as potential interaction with the other drugs and clinical status of the patient. In most cases, more than one agent is needed, mainly anxiolytic, sedative and analgesic agent combination. Administer the agent with set target in mind. The appropriate initial pharmacological agent for managing agitation should target the cause of distress. Usually more than one agent is typical and the regime may contain an agent for pain as well as an agent for anxiety, agitation and or delirium. For distress due to dyspnea or pain, opioids are the agent of choice. Fentanyl is generally the most commonly used opioid for intermittent or continuous use due to its rapid onset and short duration of action. For patients with anxiety who do not need a continuous infusion like some patients with mild to moderate alcohol withdrawal, intermittent dosing with benzodiazepines is appropriate. For severe agitation due to anxiety requiring a continuous infusion, either propofol or dexmedetomidine is preferred rather than a benzodiazepine. Exceptions include patients in whom benzodiazepines are first-line therapy for the underlying illness, like patients with alcohol or substance withdrawal. Antipsychotics can be used intermittently as supplements to other sedatives for the treatment of hyperactive or agitated delirium. While antipsychotics are effective at treating delirium, they do not prevent or decrease the duration of delirium or motility and are therefore not administered prophylactically. Choosing among the antipsychotics is individualized. For example, when rapid control of agitation is needed for acute hyperactive psychosis, intravenous haloperidol is preferred. In contrast, enteral agents are used such as atypical antipsychotics like quetiapine when chronic control is needed, for example, nocturnal psychosis or delirium, limiting the ability of the patient to wean off sedative infusion in preparation for extubation. Other factors requiring consideration includes pharmacokinetic modifying variables like age, body weight, kidney and hepatic function, drug interactions, history of alcohol or drug use. These variables affect onset, peak and duration of sedation as well as potential adverse effects, particularly during deep or long-term sedation. Known for pharmacokinetic variables include the desired depth of sedation, means it's light sedation or deep sedation, and clinical status of the patient, means presence of bradycardia, hypotension, obesity, or long QTC. For patients with bradycardia, dexmedetomidine is generally avoided since bradycardia is a common side effect of this agent. For patients with obesity, prolonged and high-dose benzodiazepines are often avoided since metabolites accumulate in adipose tissue, prolonging sedation and increasing length of stay and mechanical ventilation. For patients with the prolonged QTC interval or an agent that prolongs the QTC interval, antipsychotics are avoided to decrease the risk of ventricular arrhythmia. For patients with significant hypotension, propofol and dexmedetomidine are often avoided or dosing limited since hypotension is a common adverse effect of these agents. A small degree of hypotension is sometimes tolerated if the desired sedative effect is achieved and the patient is receiving vasopressors for another reason such as sepsis. For all patients with the severe hypertriglyceridemia, propofol is contraindicated in such patients, and for patients in whom rapid sedation is required or like patient immediately following intubation, shivering during hypothermia, or when rapid awakening is desirable like patient who require frequent neurological examination, propofol is useful because it has a rapid onset and short duration of effect. Light level of the sedation is a level recommended for most patients. Deeper sedation may be required in some patients and for that propofol is recommended. For patients with kidney function impairment, high dose lorazepam should be avoided since the diluent propylene glycol can accumulate and cause lactic acidosis. The depth of sedation required for individual patient varies. While light sedation is a level recommended for most patients, deeper sedation may be required in patients with severe hypoxemic respiratory failure and patients with ventilator dyssynchrony, patient undergoing procedure or transport, patient with cardiac devices, patients with elevated intracranial pressure, patients receiving medication for treatment of status epilepticus, or patient receiving neuromuscular blocking agents. Propofol is the agent of choice for the deep sedation because it allows relatively rapid emergence from deep level of sedation. Recovery from deep sedation with benzodiazepines may be prolonged and deep sedation may not be easily attained in many patients with dexmedetomidine alone. Pharmacological needs range widely. While some patients require minimal or no sedation, others require deep sedation. If the clinician has trouble achieving the set target, either dosing is maximized as tolerated or additional agents are administered. Usually, most patients often need more than one class of drug, typically two, since the etiology of distress is multifactorial. As an example, for a patient whose agitation is due to anxiety and pain, propofol plus an intermittent opioid is appropriate. For patients who are intubated and mechanically ventilated and not able to clearly communicate the source of agitation, in such patient, administer sedation with analgesic agents like fentanyl. Patients with alcohol withdrawal may require benzodiazepines and supplemental atypical antipsychotic for heightened periods of delusional agitation. In such patients, dexmedetomidine infusion may also be a useful adjunct in this population for difficult to control symptoms. If the distress is due to pain and an opioid is initiated, then assessment using a pain scale is appropriate. If the goal of therapy is anxiolysis or sedation, then a scale assessing level of sedation should be used. On many occasions, more than one scoring system is used since agitation distress is often multifactorial. Titrate or taper the sedative analgesic medication to meet the therapeutic goals. The most common scale used in the ICU is the Richmond Agitation Scale to assess the level of anxiety, sedation, and therapeutic goals. In the intubated patient, the ideal sedation goal is for the patient to be awake and comfortable with minimal to no distress, means 0 on the RASS scale. A target range from 0, which is alert and calm, to -1, which is drowsy, is more realistic. The goal for depth of sedation should be frequently reassessed and adjusted. The primary goal of treating delirium is that the patient be calm and cooperative or back to their baseline mental status. For patients receiving neuromuscular blocking agents, deep levels of sedation and assurance of analgesia should be established prior to the administration of paralytics. This is Richmond Agitation Sedation Scale or RASS. In this scale, patient condition is categorized into 10 different stages ranging from +4 to -5. Stage 0 represents calm and awake state, while plus represents restlessness and agitation of varying degree, which is worsening from or which worsen from 1 to 4, and minus represent drowsiness and unresponsiveness of increasing severity from -1 to -5. So to summarize, administration of sedative analgesic medication should be based on observed agitation and not on assumed distress unless the patient is on neuromuscular blockers. Selection of agent must be individualized. Agent is chosen based on underlying cause of distress and presence of any modifying variable, and often more than one agent is needed. Then set target and titrate the medication to achieve the goal target. Ideal sedation goal is for the patient to be awake and comfortable with minimal to no distress. Delirium goal is calm and cooperative patient or patient achieves the baseline mental status, and pain goal is pain-free condition. Here I finish. Thanks for watching this video. Please do not forget to subscribe to this channel. I will continue in my next video on same topic where I will discuss about administration and weaning from the sedation and analgesia in critically ill ventilated adults part 3. Till then, bye and take care.